Hello guys, welcome to my YouTube channel. My name is Sakshi and today I'm with a new topic, that is reconstructive osseous surgery, which includes bone grafts as well as GTR. GTR is guided tissue regeneration. Now let's begin without any further delay. So first, what is graft? Now let's know the definition of the graft. So graft, it is a viable tissue or organ that after removal from the donor site is implanted within the host tissue, which is then repaired, restored and remodeled. Now, what is the classification of the grafts? So, the bone grafts, they are classified according to, depending upon the sources, that is non-vital bone graft and vital bone graft. In non-vital bone graft, there is allograft, which is the human bone, freeze-dried bone allograft, xenograft, that is the anorganic bovine bone. Vital bone graft includes intraoral and extraoral. Intraoral includes osseous coagulum, bone blend, bone harvested from the extraction site. And the extraoral sites where we can obtain the graft is the iliac crest graft. According to Naser, the classification is the bone substitutes include xenograft, alloplast, and autograft. Xenografts include the bovine-derived hydroxyapatite, coralline calcium carbonate, and alloplast, and then absorbable alpha and beta tricalcium phosphate. Non-absorbable includes bioglass and HTR polymer. The classification of the grafts according to the mode of the action includes osteogenic, osteoinductive and osteoconductive. Now let's see them one by one. Osteogenic is new bone is formed by the bone forming cells contained in the graft. And osteoinductive states that the bone formation is induced in the surrounding soft tissues that are immediately adjacent to the graft. And osteoconductive is that the grafted material does not contribute to the new bone formation, but it serves as a scaffold for the bone formation originating from the adjacent host bone. Now, what are the different types of the bone grafts which are used in the periodontics? That is the autograft, allograft and alloplast. Now, in the autografts, what is an autograft? Autograft is obtained from the human individual itself. It's like intraoral site and extraoral site is there. In intraoral site, it includes the osseous coagulum. Osseous coagulum is, this technique uses the small particles of the donor bone, hence it provides additional surface area for the interaction of the cellular and the vascular elements. Now, what are the sources from where we can obtain this grafts? So, sources are lingual ridge on the mandible, exostosis, tori, edentulous ridges, bone distal to the terminal tooth. In this technique, a burr is used in the donor site to reduce it into the small particles, which when coated with blood becomes the coagulum, and then it is placed in the defect. So, this is osseous coagulum. Now, let's talk about the advantages and the disadvantages of the osseous coagulum. Now, what are the advantages? Advantages include that it is a rapid technique. It complements the osseous resective procedures that may be required at the surgical site. Its particle size provides additional surface area for the interaction between the cellular and vascular elements. Now, what are the disadvantages? It cannot be used in larger defects because of inability to produce adequate material. Then next is, it has a very poor surgical visibility, relatively low predictability, inability to use the aspiration during the accumulation of the coagulum. What is bone swedging? Now, the piece of the bone is completely detached from its base by a chisel and then it is swung into a neighboring bone defect with some of its blood supply maintained. It is the technique which requires existence of edentulous area adjacent to the defect, and it represents a contiguous or a pedicle bony autograft utilizing the principle of the green stick fracture of the long bones. So this is all about bone swedging. Now, let's talk about bone blend. It involves removing the bone, that is cortical, cancellous or both, from accessible intraoral site by chisel or Ronger forceps, placing it in a sterile plastic amalgam capsule with pestle and then triturating it. Sites for obtaining autogenous grafts is intraoral and extraoral sites. Intraoral sites I've already discussed that it includes healing extraction wounds, edentulous ridges, exostosis, lingual ridge on the mandible, bone distal to the terminal tooth, lingual surface of the mandible, maxillary tuberosity and mandibular retromolar area. Extraoral sites include the posterior iliac crest. Now, what are allograft? Allograft is also known as the homograft. Allograft is the tissue transfer between individuals of same species but of non-identical genetic composition. Bone allografts are commonly available from tissue banks. Now, bone allografts are obtained from cortical bone within 12 hours of the death of the donor, defeated, and then it is cut in the pieces. washed in the absolute alcohol, and then it is deep frozen, and the material may be then demineralized, subsequently ground and sieved to the particle size of 250 to 750 micrometer, and then it is freeze dried. So this is all about allograft. Then after that, finally it is then vacuum sealed in a glass vials. What are the types of allografts? Now there is FDB and DFDB, that is freeze dried bone graft and demineralized freeze dried bone graft. Now let's talk about the freeze dried bone graft. It is osteoconductive material, it is radio opaque, it can be broken down by way of foreign body reaction, and it is primarily indicated in the bone augmentation, which is associated with the implant treatment. And about DFDB, that is demineralized freeze dried bone graft, it is considered to be the osteoinductive material. According to lab studies, demineralized freeze-dried bone graft is considered to have high osteogenic potential as compared to freeze-dried bone graft. It is more of a radiolucent material, it is rapidly resorbed, it is primarily indicated in the periodontal disease associated with natural tooth, and successful treatment will be of DFDB plus GTR, that is guided tissue regeneration. Okay, now let's talk about the most important topic, that is GTR. GTR is also known as guided tissue regeneration. It is one of the most favorite topic of all the examiners. Even the examiners will ask this in the prelim viva, in your university exam viva, even in your MUHS periodontology paper it may come. They may ask you what is GTR, what is the procedure, what is indications, what is the concept of GTR, what are the contraindications, how it is done, and what are the materials which we use for GTR, what is the classification of GTR, everything they would ask. So just put 3 stars beside it because it's very, very, very important. Even during my final year university examination, this question was asked to me also, and I was able to answer it because I had studied it. Now let's talk about GTR, guided tissue regeneration. Now let me give you a brief idea. What is it? Now in GTR, it is the concept which it involves is placing a barrier membrane. Now that barrier membrane, it may be resorbable, it may be non-resorbable. Now we will basically place that barrier membrane in between the bone and the gum. That is, the barrier membrane placement will be such that it only allows the growth of the bone and the periodontal ligament cells, but it may exclude the gingival epithelium and the gingival connective tissue. So it is based on the assumption that the only PDL cells have the potential for regeneration of the attachment apparatus to the tooth, but there is exclusion of epithelium and connective tissue. Why? Because epithelial cells, it is believed that they interfere with the regeneration process, so there is exclusion of epithelial as well as the connective tissue cells from the root surface. Now the process of GTR offers possibility of new attachment in the teeth with advanced periodontal destruction. In this technique, matrix proteins and growth factor shows promising results. This technique involves placement of the barrier membrane which bridges the space between alveolar crest, cervical portion of tooth, thus preventing apical migration of epithelial cells from surgical flap in defective space and facilitation by repopulation by the cells of the PDL. Now what are the types of the GTR? Degradable membranes and non-degradable membranes. Degradable membranes is example collagen, polylactic acid, vicryl and guider membrane. Non-degradable membranes include example millipore, Teflon membrane, Gore-Tex, periodontal material. Now I have a diagram over here which shows the GTR technique, that is guided tissue regeneration. Now have a close view. See, first there is a vertical bone loss. We can see that here is the bone loss is seen, and even there is the attachment loss. Okay, and then in the second there is a bone graft placement is seen. See, this is the bone graft. Okay, then third, then we are going to place a barrier membrane over here. Now what is the barrier membrane? I have already talked whether it may be degradable or non-degradable. So this barrier membrane is placed between the gum and the bone. Now in this case, as it is placed in between the gum and the bone, there is exclusion of this membrane basically from epithelial migration and connective tissue migration into the graft. So there is exclusion of epithelial and connective tissue cells, and there is repopulation of this space or this defect only by periodontal ligament cells. So there is an assumption that only PDL cells, they have the ability to regenerate. Now see, placement of the membrane in between the gum and the bone. And over here now, last step is flap approximation with the sutures. Now see, that membrane is placed, the graft is placed, and then it is sutured. and there is flap approximation along with the sutures. See, attempt of reattachment is also seen over here. So this is the technique of GTR. You can have a close look. Now let's talk about indications of GTR and contraindications of GTR. Indications include narrow or three-walled intrabony defects. Next is in circumferential defects. It means when the pocket is seen whole around the tooth, that is circumferential defect. Next is in class 2 furcation defects and recession defects. What are the contraindications of GTR? Medical conditions contraindicating the surgery. Then infection at the defect site, poor oral hygiene, patients with smoking, tooth mobility greater than 1 mm, defect less than 4 mm deep, width of the gingiva at defect site is less than 1 mm, thickness of the attached gingiva less than 5 mm, when the furcation is present with short root trunks, in multiple defects and in generalized horizontal bone loss. Now let's talk about the procedure of placing the GTR. Now there are many steps. Now let's discuss them one by one. Step 1 is raise a full thickness flap extending a minimum of 2 teeth anteriorly and 1 tooth distally to the tooth being treated. Now what is written over here is we need to raise a full thickness flap, but that should extend minimum of 2 teeth anteriorly and 1 teeth distally to the teeth which is or to the tooth which is being treated. Okay. Step 2, debride osseous defect and plane the root surface. Step 3, trim the membrane according to the size of the area being treated, and the membrane should be extended approximately. Step 4, suture the membrane around the tooth with a sling suture. Step 5, the flap is positioned back to its original position or slightly coronal to it and is sutured using interrupted sutures. Then the membrane should cover completely in case of non-degradable membrane after 5 weeks of the operation, and it should be removed with a gentle tug. By this, I complete GTR, that is guided tissue regeneration. I hope you all would have loved my video, and please do not forget to like, share, comment and subscribe. Thank you.